if you are in the East, and good afternoon if you are in our region, and very good morning for those who are in the West. I would like to welcome you in our webinar today, which is organized by Al-Bahar Eye Center in cooperation with the group of guidelines, consensus, and education in ophthalmology. We will talk about keratoconus today. Obviously, we cannot cover the whole topic of keratoconus. However, we will try to stress on a few points which we think it is helpful. Since this is our first meeting in cooperation with the GCEO Group, I would like to introduce to you Dr. Anas Al-Ambari. It was actually a pleasure for me to work with him during the last few days in preparation and organization for this webinar. Dr. Anas is a UK born and trained in cornea, trained cornea specialist. He is the founder of the group of guidelines, consensus, and education in ophthalmology. He practiced in several places in UK and in the Middle East, and currently he is a cornea, cataract, and refractive surgeon consultant in the Kuwait Oil Company in Kuwait. He did his cornea fellowship at Moorfield Eye Hospital and did many peer-reviewed articles and books. He is a member of the ISRS International Meeting Committee, and he is a prominent international supporter to ophthalmic education. He received many international awards, including the American Academy of Ophthalmology Achievement Award and the ISRS Recognition Award. Please, welcome Dr. Anas.
Thank you very much, Dr. Jamal. The GCEO Group would like to thank Al-Bahar Eye Center and Dr. Jamal Al-Merjan for the invitation to participate and co-organize today's event. I must thank Dr. Jamal for all the time and efforts he put in organizing this event. I'd like to thank the distinguished faculty for their time and efforts and for their great support to ophthalmology education in Kuwait. The group of guidelines, consensus, and education in ophthalmology is a group and not a society. We are registered in the UK as an international, non-profit, non-governmental, volunteer-based group. We participate at ophthalmological educational events by invitation. The idea of forming this group came up during our work at our practices, where we noticed many patients having wrong information about their diseases and their planned procedures. So we decided to make a reliable source for the patients. We did evidence-based, simple and clear patient information leaflets on common eye diseases and procedures in both English and Arabic languages. Then made a mobile phone app to host these leaflets to make it accessible by patients to correct their information. This is the cataract surgery leaflet that describes to the patients what cataract is and how the surgery is done, as well as how to prepare for the surgery and what to expect, along with description of possible complications. This app and 2 decades of international ophthalmic education involvement together created the idea of founding this group, which aims to supporting awareness of ophthalmology consensus guidelines and continuous medical education in ophthalmology worldwide, and providing education materials directed towards ophthalmology care. The GCEO Group is the result of a teamwork of worldwide practicing ophthalmologists. We expanded the app to add materials for doctors, residents, and colleagues, as well as all medical staff, and made a login designated for medical staff only. At the medical staff section, you can find the videos page, where we accumulated videos from evidence-based webinars, whether from our co-organized events or other. Videos can be divided and classified in a special list according to individual subspecialty or preference. At the medical staff section, you can find the tools page, which includes, for example, Amsler grid to help patients test themselves regularly at home and to be used by medical staff in clinics. As well, it includes useful and important tools for clinicians. For example, calculation of residual stromal thickness for PRK, LASIK, and SMILE procedures, as well as special SMILE settings to reduce suction loss and to allow safe low myopia procedures. Other examples of tools include a tool to convert the in-the-bag IOL value to the in-sulcus equivalent value, and a tool to convert glasses prescription to contact lens prescription and vice versa, and another to amend IOL levels according to the central corneal thickness. Those are available now among many other practical and valuable tools, as well as there are many more tools on the way. Besides the hosted guidelines and the leaflet page, we made another page to include links to major guidelines and resources website, which can be a fantastic teaching resource. This app guides patients and make life easier for ophthalmology medical staff. The Android version is already at Google Play Store, ready to be downloaded. The iOS version, as well as our website, are going to be available soon. Thank you very much.
I am pleased now to introduce Dr. Margaret, who is going to talk about the current grading system and progression display for keratoconus. Dr. Margaret, she's a colleague of us here in Al Bahr Eye Center and a consultant in the cornea service. She's a member of the Al Bahr Scientific Committee for the last 10 years. She is an excellent cornea and phacosurgeon with great clinical acumen. She also actively involved in the postgraduate teaching for the Kuwait Board of Ophthalmology and involved in all academic events in various conferences and symposiums. In addition to that, she is a great person to work with. Please, Dr. Margaret.
Thank you so much, Dr. Jamal, for the kind words. And it's always a pleasure to share the platform with all the eminent ophthalmologists. It's an honor, and thank you, Dr. Jamal, for giving me this opportunity. And I would also like to thank Dr. Hannush and Dr. Jamal for the hard work to make this webinar happen. So thank you.
Next speaker is Dr. Rashid Al-Saidi, and he will be talking about customized crosslinking. Dr. Rashid is renowned for his pioneer work in corneal crosslinking and refractive surgery, as well as for his leadership and organizational achievements at the Omani Ophthalmological Society and Oman Ophthalmology Health Service. Welcome, Dr. Rashid.
Good afternoon. As Dr. Jamal said, in our area, and good morning in other area of the world. I thanks Dr. Jamal from Al Bahr Hospital for this organization and Dr. Anas, and I thank them very much for allowing me to share, to give a talk in this lectures, in this online small conference. And we thank you. And as usual, I would like to give today updates on customized cross-linking. As you know, we been using normal conventional cross-linking for more than 10 years, and recently for around 2 years or more, little bit, we started customized cross-linking for our patient. As you know, Oman, one of the highest rate of keratoconus worldwide. And one study showed, as introduction, one study showed in Oman, we conducted recently, almost 7 to 8% of Oman population, they have some degree of keratoconus. That's why a good country and good place to do any studies. No conflict of interest in our talks. As you know, as introduction, keratoconus, non-inflammatory bilateral disease of cornea characterized by progressive thinning and apical protrusion. If untreated, KC can lead to severe reduction in vision and corneal transplantation. And what we say about all those two complications actually now in Oman, especially in most of the areas of the cities in Oman, we decrease very much because of availability of cross-linking all over the country, most of the places. And as I said, this one study conducted and published already in Oman Journal of Ophthalmology showed very high prevalence of keratoconus in Oman in all regions, in all tribes. As you know, we have a conventional crosslinking for a long time being there, well-established procedure, proven effective in halting progression of keratoconus. And nowadays, some center worldwide, they started introducing this customized crosslinking. It's this what customized crosslinking? What this targeted activation of riboflavin with customized UVA light shapes to induce targeted stiffening. The study was started more than 2 years ago to report 2 years outcome of customized corneal collagen cross-linking for keratoconus in Oman. The setting was this prospective study was carried out at Ophthalmology Center Amodi Hospital, Muscat, Oman, with initial 12-month follow-up period starting from 2nd of September 2018, and we followed up those patients for 2 years now. The inclusion of the study was all patients 13 to 30 years old as a treatment date, regardless of gender or race. Established diagnosis of keratoconus with recorded progression, willingness to comply with all study instruction, cessation of contact lens wear for 1 week for soft and for 2 weeks or more for rigid permeable lenses. For important exclusion criteria, we target corneal thickness with epithelium less than 400. We exclude for this study. Known sensitivity or allergy to investigational product. Concurrent history of any other ocular pathologies, history of previous refractive surgery, pregnancy and or lactation during study period. Plus there are some other minor things we did not mention here. The method. Ethical approval taken for all patients, informed consent obtained prior to the procedure, topical anesthesia was applied as standard 1% tetracaine, 1 drops every minute for 15 minutes, epithelial debridement over the specific targeted area. It's very important. This is the difference between the normal conventional cross-linking. Here we only will remove the epithelium from over the cone area and around it. Corneal collagen cross-linking was performed by application of riboflavin followed by targeted UVA light. The treatment area and energy level were customized according to the topographic findings. Most of all patients, they get same medication, antibiotic moxiflox, fluoromethanol, and ketorolac, cyclobentalate, and artificial tears 2 hourly. So all patients getting same treatment for almost the same period. Clinical evaluation included uncorrected visual acuity, best corrected, corneal topography, K reading, corneal regularization index, RI. This is something a new index, and I'm going to talk about it. Assessment was scheduled as pre-op, post-op, 1 month, 3 months, 6 months, 9 months, and 12 months. And then 24-month follow-up was added, and this will be presented in this presentation. The safety profile, epithelium healing on day 7, delayed healing was noticed only in 1 case, 1 patient. Corneal haze on day 7 was noticed in 5 patients, all was only grade 1. Corneal haze on day 30 was persistent only in 1 patient. Corneal haze on day 90, none, and no other adverse effect noticed over the last 2 years. Example of treatment plan. The greatest energy here, dose applied over area of steepest posterior curvature, encompassing area of steepest anterior elevation as well. So we use 3 different energy, 10, 7.2 joule, and 5.4. It depends on the zone. And standard 30 milliwatt continuous illumination. As you can see from this picture, this the picture of the machine which we use. And as you can see here, we make customized circle on the steepest area, or the area where cones mainly center round, and then 2 apical round. I'll show you here better. So we take with Pentacam 2 photos for anterior axial map and posterior elevation lamp. So we try to make the circle, as you can see here, middle, and the middle one will get the circle one 10 joules, and the second one, which is not round apical, which we see it 7.2 moles, and then the third one lower energy. So we try to remove epithelium around this area, not full like the normal one. Here we can see from the example of one of the patients, sorry. Here we shall see pre-op. You can see here pre-op, the steepest area here, and 3 months post-op, and here you can see 6 months and 12 months. So this clear difference, the steepening, this flattening area of the steep area. And here from the index we can see from this combined photos or penta photography, you can see here the blue area, that's mean the steepest area getting flattened, and the opposite, the flat area getting steepened a little bit here. So this notice in all type of cross-linking, but here with customized cross-linking we noticed more actually, but still not clear how it's important for the patients. If we watch the same patient after, here we took only 2 readings, 12 months and 24 months for the same patient. You can see here the steepening get 51 here, and here getting stable or better a little bit. Here you can watch in the map difference here, the steep area flatten more in 24 months after 2 years, and you can see here it is not very clear the flat area little bit steepening happened. So here in our study 54 eyes were treated from 2nd September to 17th October 2018. 12-month follow-up data was available in 48 eyes for analysis. And after 24 months, unfortunately, not all patients were available for the follow-up, only 19 eyes. So individual comparison of each eye was done against the 12-month result. Here we can see uncorrected visual acuity in 89% improved or remained stable at 12 months. As you can see here, the improvement continue in logmar. I'm using here logmar graph, which you can see the improvement there even after 12 months. And after 24 months, 2 patients have shown slight deterioration of visual acuity and uncorrected. As you can see here, all other patients have maintained same visual acuity and after 24 months. Here I have this graph for best corrected visual acuity, and you can see here 95% improve or remain stable at 12 months. Best corrected visual acuity also continued improvement over 12 months. Here we'll see now after 24 months. After 24 months, 2 patients showed further improvement of best corrected visual acuity, as you can see here. And 1 patient showed mild deterioration, which is only 0.01 logmar. Here you can see this patient. All other patients after 24 months stayed stable. Kmax was very important factors. We can see Kmax in 61% showed more than 1 diopter flattening at 12 months. No worsening of more than 1 diopter at 12 months. So the flattening improvement always of Kmax, this 12 months. Here, if we take 24 months, 3 cases showed more than 1 diopter further flattening. That means there's improvement after. 10 cases showed 0 to 1 diopter further flattening. All other cases remain stable. So over on the long term, of which we can see here 2 years, the improvement there still, and the patient benefiting from the cross-linking. Topographic keratoconus classification, 40% showed an improvement in TKC at 12 months post-op. All 19 patients remain in same classification stage during 12 to 24 months of treatment. Regularization of index. Regularization of index corneal surface within 6 mm circle around the apex, measured by adding absolute amount of maximum flattening, usually in steep areas, with absolute amount of maximum steepening, usually in flat area. So the mean was for our case in 24 months 3.63. Our study based on the paper published by Professor Theo Saylor for this regularization index, which is still no agreement about it as a because it's not going with other factors which important like Kmax and best and uncorrected visual acuity. But it's important factor for other things in the cornea which need further study. The study done by Professor Saylor, as you can see here, we applied in, he studied 19 eyes in customized group and 19 eyes in standard group. Data collected at 1 year, so this from his study, not from our study. Both treatment showed that the customized procedure had significantly greater flattening effect and significantly better regularization of cornea compared with the standard procedure. Mean change in Kmax for the customized ad and standard group was minus 1.7 diopter and minus 0.09 diopter respectively. The mean regularization index value for two groups were 5.2 diopter and 4.10 diopter for Professor Taylor finding. In our study, but different. In our study, in 48 eyes, 1 year data analysis showed significant flattening effect on customized cross-linking. As you can see here, mean change in Kmax was minus 1.62 diopter. Mean regularization index value was 3.63 diopter. Does not, but what we saw, it does not correlate with the flattening effect and the visual gain. So we don't know how this will help. There's another study from famous Professor Farhad Hafizi, if everybody knows him. He did a lot of study, a lot of publication on keratoconus, and he noted both Kmax and regularization index, a metric introduced by Saylor ATI, according to his paper, more robustly evaluate change in anterior curvature after cross-linking, had poor correlation with change in corrected visual acuity, which his mind like this, but still is not clear actually. In conclusion, customized cross-linking was safe and effective in stabilization the progression of keratoconus at 12 months for most patients in this study group. Even after 2 years, many patients have shown stability, in some cases further improvement as well. Improvements in patient visual function were noteworthy. 2 years result of the novel application of collagen cross-linking are encouraging, and data in larger study is required. A study using EP-off customized cross-linking with pulse higher dose UVI may further improve treatment efficacy. Thank you.
Thank you very much.
Thank you.
Our next speaker now, Dr. Margaret. Is she ready?
Today I'm going to talk about current classification and progression display for keratoconus. Well, prior to this present classification, there have been many studies, publications about the grading system for keratoconus. But all these grading systems done prior were So all these grading systems done prior mainly banked on the anterior corneal curvature. With the changing times, with modern technological advancement in imaging cornea, with Scheimpflug imaging techniques of tomography and optical coherence tomography, and also with the advancement of treatment modalities, these grading systems probably will not suit to the present era. These mostly, like, they banked on the anterior corneal curvature. Definitely Kmax and the other parameters play a paramount importance. But with the changing times, when we are able to know all the layers of the cornea, recognize all the layers of the cornea, and we can detect early and subclinical stages at the very infancy, why not adapt and take the good from the modern technology? So, well, this new classification banked on this parameter, the posterior elevation, and they have graded, called Bellon's ABCD grading keratoconus staging and display. Now, do we really need this grading system? I would definitely say yes, because as I've said, the prior grading system, especially the Amsler Crumac, which has been widely accepted even now, is a 70-year-old grading system. And what does the new way of diagnosis for keratoconus outline? The study, which I had shown previously, clearly outlines the parameter of posterior elevation as one of the most important abnormality that can be picked up very early. So this is the parameter what the ABCD wanted to highlight and bring into notice, so that we pick up cases at the very infancy. And because there is also the modality of treatment like collagen cross-linking that has been developed, we can prevent progression of the disease and do not wait for the progression or change in the Kmax to apply treatment, but rather even before we have a progression or a drop in vision of a 1-2 line, we would like to treat the disease. So definitely prevention is better than cure. The study also outlined that the newer techniques of diagnosis of keratoconus play a very important role. Again, for the subclinical keratoconus, the diagnosis emphasizes posterior corneal elevation abnormality. Taking all this into consideration, the study did that investigation. Well, a word about Amsler-Crumack classification and its limitation. Though it is a 70-year-old classification, it is appreciable that even today, most of many people are using this classification. It has many limitations because this classification was developed like in 1940s. It's a 70-year-old classification when the machine used was a keratometer, and for thickness they used optical pachymeter. But now when we have tomography imaging, why not have a better grading system? So, and also it relied mainly on the apical thickness. Here again, let me tell you that keratoconus is not just cones in the apex of the corneas. We know that the cones, keratoconic cones, are seen in the inferotemporal areas of the corneas as well. So there are high chances of missing the cones. It does not take into account the posterior surface, and also there's an element of confusion in staging. Suppose a patient comes with these parameters, how do we grade the patient? Is it stage 1, stage 2, or stage 3? There is a confusion, and this confusion is very well tackled by ABCD classification, because this classification banked on not just the thinnest point, but it took into consideration a 3 millimeter zone around the thinnest point, and also it dealt with recognizing all the 3 anatomical layers: the anterior corneal curvature, the thickness, and the posterior corneal curvature. And it's very easy to interpret and no confusion as well. Now, what is the goal of ABCD? The idea with which this was developed was to prevent progression and to pick up keratoconus at its infancy in subclinical stage, so that we implement treatment right at the right time and prevent any progression. So definitely it's to look beyond Kmax, and it is easy to interpret, and not just on looking at the progression. By looking at the grading system, we can even evaluate what type of treatment we can implement for that patient. What do ABCD define? A is the anterior radius of curvature from a 3 millimeter zone centered on the thinnest point. B is the back radius of curvature from a 3 millimeter zone centered on the thinnest point. C is the minimal corneal thickness, and D is the best spectacle corrected visual acuity. Now, this is the new Bellin ABCD grading system. As I've told you, they have incorporated all the 4 4 parameters which I've discussed: the anterior radius of curvature, posterior radius of curvature, the pachymetry, and the best corrected visual at distant visual acuity. And the advantage of the system here is they included grade 0, which was lacking in the previous classification. Here, the normal people can fall into this criteria, into this group, whereas the normal population were graded as grade 1 keratoconus in the AK classification. Now, this is the topometric maps, what the machine, when we designate, we can procure from the machine pentacam, and it clearly gives us an idea of this grading system in the machine, along with the axial maps, anterior and the posterior, and of course the normal Kmax and R parameters, which we are very much acclimatized to and which we are aware of. Just to magnify and make things clearer, now this is the case, this is how the grading system comes up in the machine. Now, this is normal. The right away, even the look of it, we can diagnose that this is a normal eye. We do not see any kind, the same 4 parameters have been designated here, and the grade 0, 0, 1, 2, 3, 4 are designated horizontally. And now when you see this, there's no element of any parameter that is progressing. So that is normal. So it is a graphical display on the right side. Down is the grouping, just like the breast cancer or any tumor grading. They have graded keratoconus. Sorry, A is the anterior radius of curvature, B is the posterior or the back radius of curvature, C represents the thickness, and D is the distant visual acuity. Here are the parameters more accurate and more specific, so we can bank on this with the distant visual acuity and so on. So just by looking at it, we can know the severity of keratoconus. If you see here, the progression of the anterior elevation or the anterior curvature is way progressing. The posterior again is way progressing. Thinness is fairly decent, but then we have just visual acuity that is again falling short of. There is a drop. So it's moderately advanced. And when we see the advanced parameters, the graphical display, it is all the parameters are progressed and they're past grade 3. And here are the parameters, and the vision drop is 20/100. So by looking at this, I feel definitely this will be a time saver for us in our busy clinical practice in the OPDs, outpatient departments, and also it gives us an idea as to what modality of management the patient can fall into. Definitely, we don't bank totally on the machine, but we apply these to the clinical findings of the patient and would plan a treatment modality plan. For example, in this case, I would definitely consider a cross-linking, collagen cross-linking, even before I want any change in the anterior curvature. Wait for the anterior curvature to change and a drop in the vision. I would not wait for that, but would definitely subject the patient to collagen cross-linking. And in this case, probably we can use a combined, and definitely the age makes a difference, considering the age. We can apply collagen cross-linking with probably intrastromal corneal rings. And here, definitely, probably a surgical modality of DALK we might think of. This is, again, just to familiarize with the grading system. If we all see, these are the early stages of keratoconus. The map itself will just give us a fair idea, and the grouping A1, B2, C1, D1 will tell us that it is an early keratoconus. And this, again, if we just correlate this grading system with the axial map anterior, and we see a cone here, a keratoconic cone, and we definitely know that, and the big posterior progression abnormality. So this would definitely fall into a moderate, advanced keratoconus. And this, the graphical display and the parameters and the grouping And look at the big, dense keratoconic cone here, which correlates exactly with the graphical display displayed here. So that is the importance of the staging. Now you can pose a question when already we have an ABCD grading. Why do we need a progression display? It gives us an idea for progression. It does, but it is not specific, which I'm going to talk about. Now, the ectasia, again, we change with the changing times. We change the diagnosis, the definitions of the diagnosis of keratoconus are changing. The ectasia progression is banking on all these parameters. And if you see that, definitely, again, they included a steepening of the posterior corneal curvature. So the ABCD progression display answers this and takes into consideration all the layers of the cornea. Now, I would definitely not negate all the prior progression parameters, which give us so much of idea, and we've been using it and we still will use it. But then all these parameters deal with the anterior corneal curvature changes, except probably the pachymetry that does not define anterior corneal curvature. But definitely they do have a value, and we're not going to neglect these, but taken posterior corneal elevation as our paramount factor for the approach of treatment of keratoconus. Now, I want to specify here that we again had a beautiful refractive screening display done prior, the Bellin-Ambrosio display. This was a great screening refractive tool, very simple to read, and the color coordination helps us just to identify it at a glance. If you guys, if we remember, just a recap on what the bad display tells us, it displays all the D values, the final D here, and the color itself will give us an idea whether this is an abnormal or a normal cornea. The yellow signify a deviation of 1.6 standard deviation from the norm. The red signifies a 2.6 standard deviation from the norm. And the final D, if we see any abnormality, that would definitely give a clue that whether this is an early subclinical case of keratoconus. Yes, it does give us a lot of information. For example, this picture, if you see, these are the standard maps, these are the enhanced elevation maps, these are the difference maps. And if in cases of subclinical cases, if we see all the anterior parameters are normal. But if you see the posterior elevation map, the standard map just defines a small cone here, and which is accentuated here because of the enhanced map. And here again, it is enhanced. But to make a point clear, and of course, these are the progression maps, we can gather a lot of information and the progression index. So we gather a lot of information from these maps, but then they just want to make a point clear that bad display definitely will give us an idea whether it is a subclinical or an early keratoconus. But the idea of bad display was only to differentiate between a normal and abnormal, not specific for keratoconic cone, because we see in cases of hyperopic LASIK, the D value changes. In cases of an endothelial dysfunction, the D value is abnormal. In cases of a post-refractive, the D value might change. So the final D is not very specific to say that these are cases of early or subclinical keratoconus. So that is the reason we do not bank on the bad display or ABCD grading. Though bad display, I have already explained, it's not very accurate to pick up the keratoconic cones. Again, ABCD fairly gives us an idea regarding the progression and the severity, but this is a population-based study and it does not confine to a single patient. So it's now, again, not very specific. Coming to the progression display, it's based on all the tomographic layers. It picks up early cases, early implementation of treatment, and at a glance, it compares the baseline with the consecutive visits and documents statistically the significant change. And if to progression. This is the publication of the Dr. Bellin and team. The progression display pictures, what I'm going to talk about is being taken from, okay, this is the progression display. This is the display 1, which I don't want to talk about. And this is the progression display 2. So I just want to point out that they again took A, B, C, D as the parameters. And these are the 8 visits, the maximum 8 visits, which we can document. The first visit, the first visit of anterior radius of curvature, the first visit of the posterior, the thickness, and D. And if you see that these are the confidence intervals of 80% and 95% confidence intervals, which we take. If these patterns go forward or proceed beyond this, definitely there's an abnormality. And also the keratoconus treatment, if given, like the collagen cross-linking, is by the hatched line. And after the treatment, these drop because further studies are underway. And again, we already have a tabular form of the previous parameters, which are also incorporated in these display maps. Now, because of lack of time, probably I'll skip all this, but I want to say that they have taken normal and abnormal patients into criteria of keratoconic patients to describe those gates, which I was talking about, the green and the red gates, which I was talking about. And this normal gates would correlate to the patients of early and subclinical cases. That's why they even took the normal population. And keratoconic population, the patients of more age, the ages more or advanced keratoconus would correlate with the keratoconic population. So just want to get an idea. See, for example, in subclinical keratoconus, look at this beautiful display. All the anterior parameters are stable. Nothing is passing beyond the 80% confidence interval or even the 90% confidence interval, 95% confidence interval of the keratoconic. But if you see the posterior corneal elevation, it's way past even the keratoconic group and the normal population of the 80% confidence interval. And here the keratoconic, the normal population, 95% confidence interval of normal population. So it clearly gives an idea of the progression. So one more example, look at this. All the anterior corneal, anterior parameters are way past the confidence intervals. The posterior corneal parameters are way past the confidence intervals, and the thickness also has thinned down. This is a user operated, so it's not fed in, so it does not matter. These 3 are machine operated. A take-home message is look beyond Kmax, detect early, treat early, and ABCD definitely is the answer. Thank you so much. Thank you.
Thank you. Thank you, Dr. Margaret.
Thank you.
We are running late, actually, but there's a quick question for Dr. Rashid about the thinnest cornea which he did, and if he encountered any complication and if there is any effect on the endothelium.
Can I talk?
Yeah.
Yes. Actually, in this study, we did all above 400 micron, but we are doing actually below 400, but not in customized way, in the normal way. But for the study, around 400 to 450, the thinnest, not less.
Thank you. So we'll go now to our next speaker, and next speaker will be Dr. Susan Jacob, and she will be talking about the corneal allogenic intrastromal ring segments. Dr. Susan is widely respected for the adoption of many of her innovative techniques worldwide and for her management of complex surgical scenarios. She is a noted speaker for the keynote lectures at various international conferences. Her YouTube channel is very rich and well known. She has been the program director for the International Society of Refractive Surgery Symposium at the ESCRS, and her editorial posts included American Academy of Ophthalmology and International Society of Refractive Surgery journals, among many prestigious journals. Welcome, Dr. Susan Jacob.
Thank you so much, Dr. Anas, Dr. Jamal, Dr. Rashid, Dr. Margaret, for having invited me here, especially Dr. Anas. Thanks for inviting me to this wonderful conference. And I must say it's very good to meet my good friends, Lamis and Dr. Hannush here as well. I'll start my talk on corneal allogenic intrastromal ring segments, or CARES, which is a technique I started around 2025. And I must say that I do have a patent pending for special Trefines devices and processes used to create these segments. Let me start my talk by telling you the reason why I actually started out this technique. It was because I was doing many intacs and I was pretty happy with the visual results, but I used to come across these cases every once in a while, and this really used to put me off doing this procedure because you would come across, as any person who does large volumes of these cases would see, you would get Melles, superficial Melles, necrosis, extrusions, sometimes even intrusions into the anterior chamber. Even acute hydrops has been reported post intacs, and also sometimes infectious keratitis. These are the major complications, but of course also a lot of minor complications like haze, intrachannel deposits, and so on and so forth. And the reason I thought was to avoid these complications, and this is basically what I started, which is basically doing the same ICRS technique but using allogenic segments. So if you look at this is a Trefine that I had designed, and it's a double-bladed Trefine. And basically it cuts out this ring of donor tissue. Now the tissue could be any kind of allogenic tissue. The one that I am currently using is basically a donor corneoscleral rim. And you can see the first thing that I do is remove all the epithelium from the donor stroma, and then remove it from the artificial chamber, remove also all the endothelium. So it's a de-epithelialized and de-endothelialized stroma now, cornea now. It's just basically mostly stroma, and there's probably some amount of Bowman's membrane and predesmates layer. So now once that is done, it is cut using the double-bladed Trefine, as you can see here, and we remove this ring of stromal tissue, which is what we get, and we cut into 2 pieces. And these are simple cataract surgery instruments that I've devised. This is a keratoconic patient's eye, and the femtosecond laser channels have already been created. It's very simple to just push these segments in. You would think that this is cornea and it's difficult to push it in, but really it's really simple. You just have to kind of design simple instruments right there, which are already with you in your OR, and can easily push these into femtosecond dissected channels. And if this patient has also got, if the patient has also got progressive keratoconus, then you can also combine it with a cross-linking at the same sitting or in a subsequent sitting. So these are just some post-operative images, and you can see these are the CARES segments, very quiet and lying absolutely inert, and very biocompatible, obviously, because it's corneal tissue within the patient's cornea. And you can see also in the slit image that the depth of implantation, also as you see in these anti-segment OCT images, that the depth of implantation is around 50%. So it's really a much more superficial location than you would do for intacs. And we've seen that we get very good results with this technique. We published it in 2018 in the Journal of Refractive Surgery, and we found significant improvement in almost all the parameters: the uncorrected and best corrected visual acuity, spherical equivalent, topographic astigmatism, keratometry, steepest case, anti and posterior best fit spheres, and so on and so forth. And this was basically just the first page of our published paper. What we found was that many of the disadvantages of synthetic implants, which included all the ones that I mentioned above, were avoided by us. You can see this this picture, which I have borrowed from my chapter in the coming Yanoff and Duker edition. You can see this is an intact, and you can see this is also in this case lying quiet, but notice its posterior location. And here is a CARES, and you can see that these are more broader channels and also more superficial location. They are larger segments and also lying very quiet. Now, the one thing about synthetic segments is that you cannot implant it in very thin corneas. If you have to have a minimum of at least 450, some say 400 in the zone of implantation. And also you don't prefer to implant this in very steep corneas, more than 50 diopters, because then those are the corneas where you can, where the risk of complications really goes much, much higher. So that's one disadvantage of intacts, that you cannot put them in very advanced cases. The other thing is that you have to have deep implantation because you have to have sufficient cornea overlying the segment to prevent complications again. So the effect may be limited because of that. And of course, also you need FDA approval, at least in the US, for different thicknesses and different arc lengths. So you would have to, you are kind of constrained by the arc lengths that are available for you to use. And in other countries, you need to have a large inventory of segments of different thicknesses, different arc lengths, different base diameters, and so on and so forth. Whereas when you look at CARES, it's corneal tissue, so it's absolutely biocompatible and biointegrable, so it avoids the complications that people dread from intacts. You can also implant it in thinner and steeper corneas. After all, in DALK, you're putting cornea straight over over about 15 to 30 microns of about 30 microns of tissue. Here you're putting it into 300 or 400 microns of tissue. That's really much more safer than putting an intacts. You can also implant it in thick and thick corneas. You can put in less steep corneas, so that includes all your mild and early cases of keratoconus as well. And you can implant it more superficially, so you get a greater effect. And also you can implant arc segments of up to 360 degrees. So you with the same segment, you can just cut it to your desired length, arc segment. Everything is very customizable right there in your OR. So you can take the kind of plan that you would really like to do rather than be constrained by what is available to you. Indications are many. Keratoconus, you can do it with cross-linking, simultaneous or sequential, or you can do it in stable keratoconus, such as the older patient or already cross-linked patients. You can do it in patients who've got other reasons for corneal ectasias or irregular corneas, and you can also do it in synthetic segment complications. And I'm happy to say that now there are a large number of countries where CARES is being done now. Many centers in USA, Canada, Australia, South Africa, Turkey, Israel, Lebanon, Dominican Republic, Germany, and many, many others coming on and adopting this technique. And of course, us in India having a huge number. This is a Scheimpflug image, which shows the pre and post Scheimpflug of the cornea of the keratoconic patient. And it's been taken obviously along the same axis, centered at the lens. At the same point, the anti-surface of the lens of both of them have been aligned. And you can see the flattening that has been obtained with these segments that you can see in the green post-op, and the flattening of the cornea that is obtained with this. Here's a picture that I've taken courtesy Jack Parker from US, which also shows beautiful flattening post-CARES. Again, you can see the CARES segments within the cornea there. And you can see the flattening is just simply obvious. And this is really a beautiful way to explain to the patient exactly what you're trying to do, because this is a conical cornea and here's how we flatten it. And you can also see the keratometric values here with a lot of flattening, and the difference map of the same patient showing even up to 25 diopters of flattening. So this is a beautiful technique, as I said, in advanced cases. You can also, as I'm going to show you in this picture, do it in moderate and mild keratoconus patients. So here's a patient who had about 20 by 120 preoperatively, postoperatively came to 20 by 30, and you can see that post-CARES, this is pre-op, the second picture is post-op, and the third is a difference image. And you can see what has happened here in the post-op is that there's corneal regularization as well as the flattening of the steep axis and steepening of the flat axis, which improves the overall topography. And you can see a huge decrease in the cylinder from -7 to -2.5. And also notice the thicker implants that have been put here as opposed to the thinner in the other eye, which gives you a milder effect. So that's how you can tailor your effect, by changing the thickness of the segments that have been put. And of course, also by changing, if you want, the diameter, the optic zone, the arc length, and so on and so forth. Quickly go through some other examples. Here's a patient who improved from 624 part to 6.9, and again, a regularization of the topography. In all these subsequent images, you'll see the regularization of the topography and the decrease in the keratometric values that are seen here. Here are again customizable, as I told you, 330, 340, 360. You can put any kind of arc segments that you want to. Here's an asymmetric segment for a patient with an asymmetric cone, and you can see you can get asymmetric flattening, so inferior flattening for this inferior cone, which can again give you differential results. Again, an inferior cone. This is pre-op, post-op, and the difference map giving you about 15 diopters of flattening with a single segment that is placed below the cone. Again, different images here, but I'll actually go to this image because it's a beautiful one. It shows you how the coma of the patient can be decreased, and so the visual quality can be improved. You can see here the coma in the 6 millimeter zone has come down from 3.438 pre-op to about 0.350 post-op. So you can notice that that's the reason that patients are very happy, because their visual quality really improves. Another example, 3.407 to 0.177. So again, great improvement in coma. This is a website cornealanalysis.com, which is made by my friend Shady Awad and Jad Asaf. And you can actually use this beautifully to kind of calculate the length of your segment, the arc length, and lots of things that you can do with this website. And I'll advise anyone who is interested in looking at that website to go to it. I have no financial interest in it.
Last 1 minute, Dr. Suzanne.
Yeah, I'm done. So the change in segment thickness with time is not substantial in our experience. And we know that also shape change is not really a mathematical calculation, so it's not that crucial. But the reasons I think it does not really change substantially is because of maybe its intrastromal location, and also because maybe cross-linking freezes it in place. And I also know that Mario Nubile has posted similar results with his SLAC. These are just other examples of CARES, but what I'd like to basically end with is to say that CARES can be used as an early treatment option. It can be used for bioptics in combination with other techniques. It can be, it's reversible, and you can also use it to replace DALK because you're not losing anything. You actually can get great results. Patient can do well, and you can improve contact lens tolerance, and you can avoid all these complications that can be associated with lamellar surgeries and DALK and even OPKs. So I'm sorry, that's my clock. So to conclude, it's effective, stable, simple, safe, and reversible and adjustable technique with a very low level of rejection because of all the reasons that I've mentioned here, most important being the very low volume of stromal transfer and rapid keratocyte repopulation. And really, in our practice, we found this to be a great addition. Thank you so much.
Thank you very much. Can I just ask a quick question, please?
Absolutely, please.
I used to work back in the beginning of the 90s with Chad Rostrom at Morpheus. He used to do the corneas, used to freeze dry it in preparation for DLK at any point, you know. Have you ever considered freeze drying for these segments at all?
Yeah, actually you can. CARES, as I said, stands for allogenic corneal allogenic intrastromal ring segments. So it need not be specifically done with fresh tissue. You could do it with preserved, you could do it with processed tissue, you could do it with any kind of allogenic tissue actually. So yes, you can do it with all these sources. You could do it with any allogenic source at all and it would still be safe.
Well, thank you very much. So we move to our next speaker today. Dr. Lamis Baydoun. She will discuss the details of bowman's membrane transplantation in Keratoconus and ectasias, and will talk about DLK optical recognition technique. Dr. Lamis is an anterior segment consultant surgeon at ELSA Institute in Zurich, Switzerland. She works at University Eye Hospital Münster in Germany. She has been the academy head at the Netherlands Institute, Dr. Melles, for almost a decade now. She's specialized in keratoplasty and in DMEC in particular, and she's acquiring a PhD on rejection and graft survival in DMEC. Welcome, Dr. Baydoun.
Well, Anas asked me to talk about optical recognition techniques, and you have heard now already that there is DALK techniques for keratoconus, and I would like to introduce a technique which normally is not so known because not everybody is doing it, but that's why it might be a little bit interesting to know about it. And I will introduce bowman layer inlay transplantation because this technique is used for this as well. So I cannot advance my slides, I just realized. Okay, I see it, I do it like this, okay. These are our financial disclosures. And when we talk about the optical interface, it's important to know that you have to find two effects because normally there is just a little refractive error between the aqueous and the cornea, and then you don't see actually anything. But if you inject air into the anterior chamber, you create like a mirror effect because you will see two interfaces then. You will see an interface then that is created by this, and you have the instrument that you put on your cornea, and then you have at the posterior part the reflection of this interface. But you have to note that for the manual DALK technique, it's important to know that the half distance between the first and the second image is your corneal thickness. The second effect I would like to introduce to you is the dark band. This is an indentation effect because through this air bubble that you have in the anterior chamber, you can see this dark band from your instrument to the posterior surface, to the endothelium. And the thinner this dark band becomes, the nearer you become to the endothelium or the Descemet's membrane, and then you know which depth you are. So if we look at this intraoperative image, you can see here is the dark band a little bit thicker, becomes thinner, and here you're almost at the Descemet membrane. To go to the manual DALK technique, you create a scleral tunnel, you fill the anterior chamber with air. We use those instruments to dissect, and here you can see this image, like first you find your depth, you go to the Descemet's membrane as near as possible, and then you take your second instrument with which you just do a proximal dissection of the superior part, and then you take the second instrument and do the entire dissection over 360 degrees of the cornea. And I have a little video for you to share. This is for a patient receiving DALK, and here you see the corneal, the scleral tunnel. And after that, you fill the anterior chamber with air after doing a paracentesis. And then with this instrument, you find your dissection depth. So you carefully look at the reflection around this instrument, and then I will move it a bit quicker. So you take your second instrument in a second here, and then you start dissecting the same plane. So first you advance, and then you dissect on the same plane. You keep rinsing so that you don't have too much blood in the interface. And here you see you already use the third instrument to do the dissection over 360 degrees. And as you know from DALK technique, now you have to do the trephination. So first you remove a little bit of air, you leave a little bit of air to keep control, then you put in the dissected pocket the visco elastic, and then you can trephine. And I will move that on because you know this step, of course. And what is now the idea? So for keratoconus, we know there was always penetrating keratoplasty as a good option to treat keratoconic patient where we have a good result, mainly compared to other indications. And we know that with DALK, we have even better option for patients with keratoconus due to the preservation of the endothelium. But actually, in 2010, Melles introduced this intrastromal implantation of the bowman layer. And the idea was because actually you know that there are different treatment options for keratoconus, and you just heard crosslinking as an option to halt progression in those eyes. We had the problem that you had to keep patients advancing to getting a PK or a DALK. That means if a patient had progression but a too thin cornea, then it was impossible to do crosslinking at those earlier times. So that's why Melles invented the bowman layer technique as an alternative for those patients to postpone the more invasive treatment with PK, for instance, and DALK. So this was the niche of patients that had no treatment because they actually were seeing still quite well with scleral lenses or contact lenses, but they were still advancing, but too thin, as I just said to you. So those were the target. This was the target group, patients with high Kmax, thin corneas, but still good vision. And therefore we thought this could be a good option to halt progression. Because of course, you know, even though the prognosis in patients with keratoconus is quite well, we still have patients where we have some kind of complications. And the idea was, why a bowman layer? We know that in keratoconic patients, we have the bowman layer or the bowman layer being sick. So therefore we thought maybe by transplanting this layer, again, we would stabilize the keratoconus. And since it is an acellular layer, you have like in DALK, no risk for rejection. Here you see the preparation of the bowman layer. This we do in the eye bank in Rotterdam, where you create this thin roll, just like you see in DMAC, for instance. Takes a little while to prepare this, but if you have an experienced technician, then you are able to achieve this. And here you see the surgical technique. It simply looks the same like with the DALK technique. The only difference is that you are dissecting a different depth. So as I said, in DALK, you try to achieve as far as possible the depth near the descemet membrane, whereas in this technique, we aim at the 50% depth of the cornea. And as you see in the video I've just shown you, this is dissection, and then you practically, after staining the bowman layer, you inject it into this pocket and unfold it. I will show it to you shortly in a video because there is a little bit of time left. So here you see the scleral pocket. First you create the sclerocorneal tunnel, then you do a paracentesis, you inject air. And after you inject the air, you start with the dissection. You first aim at the 50% depth. Then you dissect the proximal part, so it's just the same. And those, as I said, those optical phenomenon, they help you in finding the depth. And here you do the inferior part, and now I show you how, because now you reduce the air and now you put the glide into this pocket. Before you decellularize the bowman layer with alcohol, and then you stain it with trypan blue, and here you see how the bowman layer is injected into the pocket. And then this step takes quite some time, so you have to be patient here to unfold it by fluid and mechanically with your instruments to finally get, I show you the final position. So this is how you try to unfold it. You always monitor the air bubble in your anterior chamber. You know, these are young patients that are phakic, so you want to make sure you don't damage anything. And in the end, you have this situation. Well, then the surgery is finished, and usually you can see with the OCT the bowman layer here in midstromally, and usually we see a flattening of the cornea about 7 to 8 diopters, and the cornea thickens, of course, a little bit. Important, you have to know visual acuity remains stable in those eyes, so you should tell the patient that vision is the same, and that's why those patients should always have a good vision before you start surgery, because there is no improvement after that. So these are the main targets for dissection techniques. You can either get a DALK or you can get a bowman layer transplant, and the positive things about it is that it's a controlled technique, and bowman layer, even you have an uncompromised anterior surface of the cornea. You have no rejection. It's efficient use because you can use the bowman layer and you can use a DMAC graft for another surgery, and you may possibly postpone more invasive treatment. And with this, I want to thank you for your attention.
Thank you, Dr. Susan, for this nice presentation. Lamis. I have a quick question here about the complication rate. Is it comparable with the usual technique, the big bubble technique? Or?
Thank you for that question. Actually, since it is, I can only speak in our hands. So since it is a technique where you can control the dissection, you may have a perforation. So I don't do big bubble technique, so I don't know how often, for instance, Sadir would have a perforation. So he will tell us in short. But I can tell that it's controlled. So in our series, for instance, there were only 1 to 2 cases that had a perforation, and then you can definitely control it a bit more. So you can postpone this next surgery. You just say, okay, we'll stop it here, or you'll continue. So I don't think that it's the same complication rate. Perforation may be a little bit less, I must say.
Thank you. Now, our last but not least speaker will be Professor Sadir Hannush, and he will walk us through the DALK big bubble technique. Professor Hannush is an attending surgeon at cornea surface at Wells Eye Hospital. He is a professor of ophthalmology at Thomas Jefferson University, medical director of Lions Eye Bank, Delaware, Pennsylvania, USA. He has 15 visiting professorship. He received the American Academy of Ophthalmology Life Achievement Award. He also did 5 clinical trials and 42 peer-reviewed articles. He did 19 book chapters, including cornea with Melles and Holland. He is an authority in cornea. Welcome, Professor Saidi.
Thank you, Dr. Jamal, for that kind introduction. It's a pleasure to be with you all. I have to thank Dr. Jamal for chairing this session and Dr. Anas for your tireless work to put this together. My financial interest is one, I'm a consultant for COA. As you know, COA is bringing a Rho kinase inhibitor to the market, which we are now evaluating with decimate stripping only. So many years ago, in previous editions of Cornea, Dr. Manus in Holland asked us to write a chapter on the preoperative considerations in decision-making in keratoplasty. And of course, the question is, what procedure is best suited for the patient? And for decades, we did one procedure, a full-thickness corneal transplant for all corneal afflictions and maladies. And now we are able to do layer-specific keratoplasty, which is an exciting time in the field of cornea. So with DALK, we are basically replacing the anterior 96% of the cornea, and with endothelial keratoplasty, the posterior 4% of the cornea. The best way to manage advanced keratoconus is not to get it in the first place. That's why the works of Dr. Rashid and Dr. Margaret are very, very important in trying to identify and treat patients early so that they would not require corneal transplantation. Now, the indications obviously for DALK and other anterior lamellar procedures are corneal ectasias, stromal dystrophies, and scars. This is known to all. The major advantage of DALK is to eliminate endothelial transplantation, because with the endothelium in these patients is healthy, and therefore why transplant it and increase the risk of allograft rejection. The other advantage that's not spoken of very frequently is that you have a closed system, and therefore the risk of a posterior unpleasant phenomenon, suprachoroidal effusion and hemorrhage, is almost eliminated. So this is an important advantage, not to mention the risk of wound dehiscence after a full thickness transplant. All of us who practice penetrating keratoplasty for decades would average 1 or 2 patients a year who would get up in the middle of the night, hit their head against the corner of their nightstand, and dehisce the wound, auto-express their lens, and frequently lose their eye. When I met Professor Muhammad Anwar many years ago, he tried to explain to me how DALK, how the big bubble procedure worked. And after an hour sitting with him, I had no clue what he was talking about, frankly. Fast forward 2 or 3 years, I decided to adopt this procedure. And what I thought was very helpful to me is to create an animation of how this works. And we did this with a graphic artist, an animator. And I want to share with you one important aspect of this that is frequently not discussed. People always ask, where are you injecting the air? Are you really injecting it at the pre-decimate level? So if you look at the insert in the upper right-hand corner here, we are trying to inject the air as posterior as possible, but the potential space, be it pre-decimase or be it pre-decimate layer, is not where the cannula ends. The cannula ends just anterior to that, and the pathway of least resistance for the air is posterior. So if you watch the insert carefully, you're injecting the air, and you are cleaving off either decimase membrane or the pre-decimate layer. Okay, once you're able to do that, the rest of the procedure is really simple and uncomplicated. And I'll show you one more important thing in the animation. So this is how the eye looks after the injection of the bubble. Again, please draw your attention to the insert in the upper right-hand corner. And as soon as we decompress the bubble, you have about 200 milliseconds to pull your sharp knife out before Descemet's membrane or the pre-Descemet layer, also known as DUAs, moves anteriorly. Okay, so that's the whole concept. Usually when you show an animation, the audience may think you don't have a real case to show. So here's a patient with an intact swing segment who did very well for many years. He presented to our service with further advances his keratoconus, asked if he had other options, and we recommended a big bubble deep anterior lamellar keratoplasty. The intact swing segment was removed, and you see me here injecting the air. And again, another pearl in the teaching here is that when you are injecting the air, you have to differentiate between the collateral damage, as they call it in the military, not a nice word, the difference between the collateral damage and the actual air bubble. So here is the emphysematous dissection of air. This is not the big bubble, but when the big bubble starts developing, you have no doubt in your mind that this is indeed the big bubble, right? All of you have seen this big bubble develop, and people think that it stops at the trephination mark. That's not always the case. Once that is done and you are confident that you have a big bubble, you know that that big bubble is either pre-Descemet layer, PDL, or it is post-PDL. Anyway, you remove the anterior lamellae and you decompress the bubble. So this is the bubble that I put in the anterior chamber, and between 2005 and 2013, when Professor Dua published his major paper, I truly thought I was looking at Descemet's layer here. And I would tell the resident or the fellow, look, we're looking at Descemet's membrane, look how clear it is. I would be impressed by that. But then I would start touching it with the tip, the 19 gauge cannula of a basal saline solution bottle, and the thing was very firm. And I know Descemet's layer cannot be that firm. So, but still didn't know what was going on. We thought we were looking at Descemet's membrane. All right. We removed Descemet's membrane off the donor and brought it over the surgical field, sutured it into position using your technique of choice. And the procedure was terminated. We gave a lot of attention not to go full thickness with our needles because we did not want to perforate and create a possible double anterior chamber, a known complication with deep anterior lamellar keratoplasty. In about 2008, 2009, we started reviewing our cases with Professor Sarnicola from Italy to try to see what we can learn, what we can do better. This is at the same time as we started giving our course at the American Academy of Ophthalmology. And I'm going to share with you some just simple pearls. Everybody on this conference knows these, but they merit repeating. Please don't remove Descemet's membrane off the donor until you are sure you're going to do a DALK, especially if the endothelium is healthy on the donor. So sometimes people are in the habit of just removing Descemet's membrane before they start refining the recipient. Well, if you do that, then you do not have the option to do a full thickness transplant if you have a large perforation during the first parts of the DALK procedure. Once you are confident that you're going with the DALK, then that is the time to remove Descemet's membrane off the donor. Okay. Now, if you are someone who likes to play loud music in the operating room, we're talking about hard rock here. This is not the time to play the music. You really, really want to have a quiet room as you're injecting the air. And what I want to show you here, and of course, all of you will recognize what has happened there. So I'm going to repeat this slowly. I basically started injecting air, and I'm going to slow this down. And then if you look inferotemporally, I started getting resistance, significant resistance to the air. I knew I had a big bubble, but I wanted to extend it all the way to the trephination mark, despite significant resistance. Well, there's a reason why it's not extending to the trephination mark. And obviously I popped into the anterior chamber. Not a desirable development, right? So this is a coronary artery spasm-inducing moment. So if you are injecting air and you get much resistance, stop. You already have most of the big bubble created, and you don't need to do this anymore. And all you need to do is stop, and you can finish this with manual dissection, okay? All right, so stop if you get lots of resistance. Now, how to decompress the big bubble, and this was referred to historically as the brave slash. Well, I'm not a very brave person, and I don't need brave slashes in my life. So one thing I've learned is to, you'll see me here putting a bubble in the anterior chamber. This has been published by many. And watching how the sausaging of the bubble is around the big bubble. This is confirming the creation of a pre-decimase or a pre-PDL big bubble. And then once you do that, you know for sure you have a big bubble. And what I like to say here is, if you are someone like me who makes that paracentesis to put the bubble in the anterior chamber after you create a big bubble, please make your incision more vertical than you would do most of your paracenteses, right? All of us are used to making paracenteses when we do cataract surgery, and we usually make them kind of at an angle flat with the iris. Well, if you do that and you have a long tunnel, you are likely to pop the big bubble internally, and you don't want to do that. So this paracentesis has to be more vertical, okay? Here I am putting a cohesive viscoelastic on the cornea when I make my brave slash. And the beauty of this, it slows down the egress of air from the big bubble. And when you slow it down, you have plenty of time to remove your knife from the eye. Instead of 200 milliseconds, you may have a full second, which is a comfortable situation, and prevent damage to the pre-decimate layer and decimase membrane by the knife if it stays there too long, all right? When you're removing the posterior lamella, you need to make sure that it's completely separated from the pre-decimate layer. If not, this is what can happen. Watch the next cut with my scissors. All right, aqueous came through. And the reason that happened is because I was not completely separated here from between the posterior stroma and the PDL. And when that happens, you perforate, not a reason to abort. You can just finish this procedure as a DALK. It requires a little bit more attention to detail. So be careful. Don't cut the posterior stroma unless it has been separated completely from the PDL, and I'll show ways of doing that. So here is another case, and you see me entering vertically to make my paracentesis. This is after the big bubble was created. I'm going to put a bubble in the anterior chamber, and instead I get all these fish eggs, not a problem. But here's the technique of making sure, and I'll show it again so that everybody can see, making sure that the separation of the posterior stroma is completely extending to the trephination mark. Once you do that, the risk of lacerating the PDL or decimase membrane is minimal. All right, so one more time, and it'll appear later in this talk. I'm going to show one more time. You are using here, there are many marginal dissectors on the market. This is simply a cyclodialysis spatula, and I'm making sure the posterior stroma is completely separated from the pre-decimate layer all the way to the trephination mark. All right. Many instruments have been developed. These are the TAN instruments with a marginal dissector, and the scissors with a longer posterior blade that protects the PDL while you're cutting the posterior stroma. Moria has created a disposable version of the Hanna tree fine that we all loved, that the Professor Hanna at Hotel Dieu developed in the late 80s. I have no financial interest in this, but I love this instrument. Something happened in September 2013. What happened? Well, Professor Dua's group from Nottingham described this layer in the posterior stroma, and for the last 8 years, it has created a lot of excitement, a lot of resonance, but on the other hand, a lot of negativity. And the negativity all arose from the fact that the Dr. Dua's fellows decided to call it the Dua layer. You're supposed to die before anything is named after you. Of course, we don't want Professor Dua to die. We love him. He's made huge contributions to the field. So let's go with pre-decimase layer, 5 to 20 microns thick. about 5 to 11 lamellae of collagen fibers, predominantly type 1 collagen with a high content of elastin-like fibers. This is important. We can talk about that separately. This layer is either acellular or paucicellular. You don't see keratocytes in this layer. Has a high bursting pressure. This is critical. So the bursting pressure of Descemet's membrane may be 25 to 30 millimeters of mercury, but the pre-Descemet layer has a very high bursting pressure. And that's why we now know why it helps us with DALK. And we think it's continuous with the trabecular meshwork, a subject of a different discussion. So here is Dua's layer, here's Descemet's membrane. And we used to think when we got a type 2 bubble, and I'll talk about that momentarily, it was an intradecimetic bubble, but it's not. It's between Descemet's membrane and Dua's layer. We also used to think that when we got the intradecimetic bubble, it was between the non-banded and the banded zone of Descemet's membrane. It is not, all right? There are several clinical applications to the pre-Descemet layer, but the most important one is to recognize what type of big bubble you got, and this will aid you in completing the procedure successfully. So big bubble type 1 is develops anterior to the pre-Descemet layer, also known as Dua's layer. Big bubble type 2 develops between Dua's layer and Descemet's membrane. So this is an important concept to understand, because once you recognize what kind of bubble you have, then you know how to move forward. And of course, some people have used the term big bubble type 3 when you have a combination of the type 1 and the type 2. Most of the time, you get the big bubble type 1, which is a safe way to proceed with DALK. If you get a big bubble type 2, it's a fragile situation. You have to be very careful in removing the posterior stroma to avoid perforation. Okay. Now, another feature of the development of the big bubble is with type 1, the bubble develops from center to periphery. All of us are familiar with that phenomenon. While in big bubble type 2, the bubble develops peripherally very, very quickly, all the way to Schwabe's line. And that is a recognizable phenomenon when it happens. I had to mine hundreds of videos before I found this in the late 2000s, but I'm happy to share it with you. So this is a big bubble type 2. Notice how it goes all the way peripherally. Notice that there is very, very little collateral damage, if you will, which is the emphysematous wave. Let's show it again. I'm injecting air. The air is going immediately to the space between Dua's layer and Descemet's membrane. And the importance of this when you get it is you have to be very gingerly, very careful in removing the posterior stroma. And look what happens here. These are rounded scissors. They are not sharp. I'm removing the posterior stroma. I did not recognize that the structure here is actually Descemet's membrane as opposed to the pre-Descemet layer. As soon as I touch it, I pop into the anterior chamber, okay? So this is important. I'll show it again. Again, this is at a time where we did not know about the Dua's layer. So we didn't know the difference between this structure and anyone in big bubble type 1. And as you see here, I barely touch it and I have a perforation. Not a problem, not a reason to abort, but it's good to understand. So some surgeons have decided when they know they got a big bubble type 2, not to remove the posterior stroma. They feel it's safe. They leave a layer behind. They know the visual acuity will not be as sharp as if you remove it, but they think it's adequate and much safer to be able to complete the procedure as a big bubble technique. So if you have $300,000 to spend on an intraoperative microscope mounted OCT, instead of sending your kids to college, then this is a wonderful device to have. It's very helpful in surgery. As you can see here, you can tell exactly where the big bubble is. You can tell the extent of the big bubble, and it decreases the chances of perforation if you are trying to expand the bubble with a cannula. Now, I'd like to show you something here. This is a patient, as soon as I started injecting, I saw bubbles, all in the anterior chamber. So I knew I had a perforation in the pre-Descemet layer and Descemet's membrane. So you may say, okay, time to convert to a penetrating keratoplasty. Well, the answer is no. It is not time to convert to penetrating keratoplasty. You have a single perforation, and there's no reason to convert. Lamise was talking about this earlier, and she asked very diplomatically, I'd like to know what the incidence of Sadi's perforations are. And Lamise, they're not low, they're high. So if you ask me how frequently, easily 20%, okay, guilty. But the vast majority of those can be saved and maintained as a DALK, not converted to a PK. So what you see me doing here is I'm going to, and I'm preparing you for what you're going to see, I'm basically going to inject balanced saline solution and thicken the posterior stroma, and then do a layer by layer dissection, similar to what Professor Barraquer described many, many years ago. And watch, let me go back a little bit here to show after removing the last layer, look how pristine the posterior stroma is. This is neither Decime's membrane nor the pre-Decime layer. It just has about 80 microns of remaining stroma, and it's pretty clear. So this patient will have good vision at the end in the range of 20/30 or so. Okay, a layer by layer dissection. And you can bring a case like this with a scar, which has a higher incidence of perforation because of the adhesion of the posterior stroma to the pre-Decime layer. You can bring it to a very successful conclusion with a good visual result. Well, what about the double anterior chamber, the nemesis of DALK surgeons? You think you did a beautiful procedure, and over the past 15 years, I would get calls from colleagues who will say, Sadir, trust me, I did a beautiful DALK. There was no perforation. Why did this happen to me? Similar to colleagues who call you and say, it was a routine phaco. I don't know why the cornea decompensated. Now, notably, most cataract surgeons do not do endothelial cell evaluation on their patients before cataract surgery. So here you have a double anterior chamber. You can see that the donor is very edematous. This is post-DALK. And as soon as you remove the air or the viscoelastic from the interface and the endothelial pump starts pumping fluid, before the patient leaves your office, again, before the patient leaves your office, you can convert this, you can reduce this like you would reduce a hernia, this double anterior chamber, and the endothelium starts decompressing and defervescing the donor stroma. Okay? For the people, for the attendees of this lecture, if you want to take a picture of, this is my rebubbling kit. I use it for DALK. I use it for DMAC, for DSAC. This is my standard rebubbling kit. I do all these rebubblings in an upright position in the office. I know the in Europe, you frown on that. I think you like to take them back to the operating room. That's a different story for a different time. But this is how we. Now, one thing that is not discussed, everybody talks about putting a bubble in the anterior chamber to reduce the double anterior chamber. But what if you had a layer of viscoelastic in the interface that's going to prevent you? So by the way, no dispersives in DALK, no dispersives in DALK, should use a cohesive viscoelastic. But if you have something in the interface, a bubble in the anterior chamber is not going to be able to blast it out of there. So one thing I do on every, not that I have too many double anterior chambers, I put the bubble in the anterior chamber, and then I go to the graft host interface and part it a little bit, and then squeegee any fluid or viscoelastic that's in the interface, again, in the same sitting at the slit lamp to bring the pre-Decime layer and appose it to the donor. Once you do that, the cornea starts defervescing again before the patient leaves your office. All right, I have a few more minutes here, so I'm going to finish with showing you an interesting case. This is a patient with a herpetic scar, and you may say, okay, what's the big deal? Well, the big deal are there are adhesions frequently posteriorly, and I'm not going to go through the whole video, but I'm going to show something which I think is important. So basically here, I'm using the Hanna tree fine. I'm going to tree fine to about 300 microns. I've been doing this for a long time. reasonably proud of myself, but I know I could get problems. So here is a diamond knife to go a little bit deeper based on local pachymetry, because as you know, the deeper you go, the more likely you are to get a big bubble type 1. And I'm going in with a Fogla probe. But I noticed when I put the probe into the eye, it was wiggling a little bit. Wiggling is not good. It means it's in the anterior chamber. It's not in the posterior stroma, as you see there. So I said to myself, okay, let me see what happens if I go again. Anterior chamber again. Not good. So I have a perforation. I'm going to go somewhere else. Take my 27 gauge needle, start a small track, then go in with my probe. And now no wiggling. So I'm happy. Nice big bubble, but there's a small air bubble that went into the anterior chamber through the previous perforation. Look again, big bubble, but there's an air in the anterior chamber. So I'm very, very happy that I got a big bubble, but on the other hand, I know there's a perforation. Now, the important part of this video is to say to you, you have to be mindful of this. So let's move forward here. And I put some air in the anterior chamber. And now I'm going to put my viscoelastic, again, a cohesive, between the stroma, the posterior stroma that is, and the predestinate layer. And I'm going to start excising the posterior stroma. But I know there's a perforation somewhere here. So I have to be careful. Here I go with my marginal dissector. I know the big bubble did not extend all the way to the trephination. So I'm using the marginal dissector to carefully do a manual dissection to separate the posterior stroma from the predestinate layer. At that point, I can safely remove the posterior stroma and complete the procedure. I am very fond of using an instrument, in this case a marginal dissector, to make sure the posterior stroma is completely separated from the predestinate layer before you put your scissors there to remove it. Okay, once you do that safely, you can remove the posterior stroma. And once that is done, obviously, you go to your donor, you strip Descemet's membrane, usually the PDL of the donor stays on, not a big thing. Here I am making sure the endothelium is devitalized, and I remove it with Descemet's membrane. And then we're going to simply transfer it onto the recipient and suture it using the technique of your choice. All right? So in conclusion, I think anytime you have a healthy endothelium with a corneal scar or an ectasia or a dystrophy, it is reasonable to consider DALK. You have a secure wound with DALK. The incidence of allograft rejection is much lower. But like a game of chess, always be ready for the next move that the patient's eye may present you with. It's nice to be ready several moves in advance. Now we have about a decade and a half experience, at least in my practice. And of course, Professor Anwar described this almost 2 decades ago. So we have a lot of experience with DALK. Still, the adoption rate is very low for many reasons that are beyond the parameters of this talk. And some people also don't have access to tissue in parts of the world. That's why I'm very impressed by the work that Dr. Susan Jacob is doing to try to avoid getting to this stage of keratoconus, and by the works of Dr. Baydoun to stabilize the cornea so that all you need is a fortification with a layer of bowmans before the patient's vision deteriorates to the point that they need a graft. I think it's very good to be mindful of the predestinate layer, also known as DUAs, because it is critical to the success of DALK. I really appreciate you asking me, Dr. Anas, to be part of this symposium, and to Dr. Merjan for organizing it. Thank you all for your attention.
Thank you, Dr. Hannush, for this very nice presentation. We have a quick question for Dr. Lamis. about the implantation of the bowman membrane. How it can reduce or stop the posterior progressive steepening?
Yeah, thank you. I didn't reveal this during my talk, that's true. Actually, the thing is, when you do the 360-degree dissection, and then you put the bowman layer, so our theory is that by pushing the bowman layer into the very peripheral pocket, and by the wound healing process, this kind of flattening is happening. This is how we theorize it. So you push the bowman layer, you try to get a large bowman layer, so you push it into the very periphery manually, and by this you assume to have the flattening.
Yeah, thank you. There is another question for
there's a question for Professor Hannush, asking about what preparation do you do for before DLK in a patient with herpetic eye disease previously?
I assume the surgeon is asking about medical preparation. If that's the case, all of these patients are on a prophylactic regimen of antivirals. We use, if they are quiet for 6 months, we make sure they're still on valacyclovir. The brand name in the US is Valtrex, 500 milligrams to 1,000 milligrams once a day. That's the only preparatory step we make. Now, it's nice to have anterior segment OCT, of course. Most surgeons have access to anterior segment OCT to see if the scar extends posteriorly. If it doesn't, then you can avoid putting your cannula in that area, and you have a normal big bubble challenge like any other case. If it extends all the way to the predestined layer, then you have to be very careful as you inject the air, because there are adhesions in that area. And what I said in the beginning of the talk, if the bubble does not go through that area, that's fine. You can stop, not keep injecting and bursting into the anterior chamber, but rather do a manual dissection. I hope that answers the surgeon's question.
I think, yeah, beautifully. Is there any comment on how long should the patient use the antiviral drugs?
Yeah, so I mean, that is a topic that comes up all the time, right? So we know that oral antivirals are extremely safe, assuming there's normal kidney function. So it is not unreasonable to have patients on oral antivirals indefinitely, especially after a graft. We certainly do that. They just need a complete blood count with platelet count and a renal function test, creatinine, BUN on a yearly basis. And in most of our patients, unless they are very young and in a childbearing age, we have them on oral antivirals indefinitely.
Well, thank you very much.
Thank
Am I
you.
allowed to ask Sadir a question?
Sure.
Thank you, Sadir, for this beautiful pearls, really condensed in this talk. You said that some people avoid going deeper if they had created a big bubble type 2, and then you have, for instance, 80% of depth. How much can we tolerate for the graft that then has to be knitted over? Can you comment?
That's, that's the question of the last half century, right? So Professor Barakir basically taught us that if you can get down to 80 micron residual depth, the keratocytes in that area are few and far between, and you're likely to have very little inflammation and scarring. So the only thing you have to worry about is the smoothness of the surface. So I think when you say how much can we tolerate, as long as the residual depth is sub 100 microns, I think it's reasonable to leave it behind if you are not facile with removing it and risking perforation of Descemet's membrane. And I think this is only an issue with big bubble type 2, of course. And so I try to make a decision. I take my pachymeter, I measure If I feel I'm still at 150 microns, I may try to dissect another 50 or 70 microns and try to get to below 80 microns. At that point, and of course it depends on who's doing the procedure. Faculty, professors love to say my fellow was doing this and that's when the complication happened. No, I was doing this and the complication happened to me. But sometimes you get overconfident. Cataract surgeons get overconfident after their first 50 procedures as a second or third year residents. Only then do they drop the nucleus on the macula. Like it doesn't happen in the first 20 cases. Same thing with me. I mean, if I get too comfortable, I may make a little error or so. But the general rule, if I can get down to a sub 100 microns, maybe even sub 80 microns, I'm safe to leave that behind. But the vision will not be as clear as if you remove it.
Thank you.
Okay, is there any other questions?
I think Dr. Margaret is trying to ask a question, but her microphone is muted.
No, we cannot hear you, Dr. Margaret.
Yeah, Dr. Susan, just wanted to ask you, does the length and thickness of the segment matter in this procedure?
It does matter. The length, kind of decides what you're going to correct more. So if you have shorter arc lengths, you're going to be correcting more of cylinder. If you're having two segments on either side, if you have longer arc lengths, you correct more of your spherical refractive error. And also if you're placing a single segment,
just like the synthetic.
It's very
just
much
exactly like
it's very much like intact.
synthetic eyes.
Yes, yes. So if you're a single segment, then you correct a lot of irregular astigmatism and coma. And also the thickness is also similar.
All right, thanks.
Okay. Any other question? All right. Okay. If there is no question, then we conclude our webinar today. I would like to thank our speakers who shared their knowledge with us today. And I would like also to thank all the attendees for their time. Also, we are thankful for the GCEO Group for organizing this meeting. And we are also grateful for Doc Mode for platform and the technical support, and to the ATC Kuwait for their non-restricted support for this event. May I ask the audience, please, to click on next, so to give feedback in preparation to receive the CME certificate. And we hope we will see you in the future with another webinars in the future.
In Kuwait City, though.
Yeah. In Kuwait, inshallah, next time, inshallah, after this Corona things finish. Thank you. Thank you all. Please. Thank you.
Thank you.
Jamal.
Bye,
Everyone, Tejas, thank you very much for making this possible.